DJ LeRoy.
NightWatchman, how you doing, buddy?
I am well. How are you?
Not bad. You know what, NightWatchman, it does seem like forever since I've seen you, man. How have you been?
I've been pretty good. I've seen you because I keep watching our previous shows, so so I see you all the time.
Yeah, I knew you had to throw me a curve there, so that was a pretty good one, pretty good one. Well, one of the things, as you know, yes, of course, you already know that I'm the recipient of a new hip. And so I feel good. I feel strong. So we're going to get out. We're going to be doing the 5-borough bike tour next year. Okay.
I'm in. Yep.
Okay. All right. So, so why don't we talk about some health? Why don't we talk about health, especially in our community? What do you think about that?
Absolutely. We've had, we live in a community that has had significant health challenges, as well as your former community, the Bronx, also very challenged.
Yeah. Wow. Well, I understand we might even have someone from as they say, the BX, baby. Okay. So why don't we do this? Why don't we bring out Dr. Danielle Greene? All right.
Okay.
Yes. Hey, Doc, how are you?
I'm good. Good evening. Thanks for having me.
Beautiful, beautiful. Did you know, NightWatchman, that she is the Chief Operating Officer for the Pandemic Response Institute for, of course, CUNY School of Public Health, and CUNY Executive Director of Public Health of State and Local Public Health Initiatives. Did you know that, NightWatchman?
I did. I read up on it late last night.
See, I'm tired of you throwing these curves. I'm just tired, okay?
Reading is fundamental.
You bad guy. Anyway, on that, I'm not...
The health, too. We're making it all connect.
God. So NightWatchman, this is going to be one of those shows, huh? You're coming for me, huh?
Absolutely.
Well, maybe I'll find an ally in our next guest. What about that?
I'm sure you will. So let's bring her out.
Mitch Stripler, come on down.
All right, I'm Team Curtis. Team Curtis.
Yeah. I love him already. All right.
Okay.
As a matter of fact, you know what? You know what? I may just silence all other mics except for Mitch's. That's right. Who is the director of the New York City Pandemic Response Institute. Okay, and this is what we'll start. Okay, here, let me just take a little calming thing right now. So please, Dr. Greene, tell us about your journey. Tell us how you came into this particular space for health initiatives and disparities.
Oh, absolutely. So I found public health at a young age because I was looking for something that combined all my interests: social work, law, urban planning, mental health, and making a difference, disparities, and making a difference in the world. So I traveled through school and grad school, and was fortunate to start at a time when some seminal literature was just published. I'm referring to McCord and Freeman's article about the lives of young men in Harlem. McCord just passed, but that was a seminal article. And that came out just before I went to grad school. And then I ended up working in Northern Manhattan on HIV and AIDS, particularly how it affected women, children, and young people, something that wasn't as focused on at the time. Actually was working for Columbia University at the time, where Mitch now is.
Wow.
Moved on from there to working for the city health department, then the state health department. And now I'm at CUNY in this wonderful role where I spend half my time on government affairs and service projects, and the rest of my time working with Mitch to build up this Pandemic Response Institute.
Love it. Okay. And so, Mitch, Same thing. And by the way, now I already know about Danielle growing up in the BX. Mitch, where'd you grow up? And tell us about your journey, man.
Since you asked so nicely, Curtis, no. I'm from deep South Georgia originally, Jimmy Carter territory.
Nice.
And
okay.
I'm an emergency guy, and I work for the state of Florida on emergency responses. I've responded to about 24 federal emergencies and disasters. And when I started, I worked on Katrina, I worked on other hurricanes down there, and came to New York City in 2008, working for the health department as an assistant commissioner. Later on, responded to Sandy, responded to H1N1. And I felt like we were always doing good work, right? You're out there, you're deploying resources, you're trying to get them to the communities that need them. But you could see in these emergencies, the health disparities that were happening with underserved communities. And I felt two things, right? I felt like we weren't helping them, right? They were out there, I could feel that in Katrina, I could feel it during Sandy. We weren't reaching that need, but also something about the response was making it worse sometimes, not intentionally, right? People were doing such good work out there helping the community, but something about the way it was happening, right? The kind of command and control structures or the militarization of it meant that it could make those disparities even worse, right? During emergencies, the people who have some get more, the people who don't have anything get less sometimes, was the way it was working out. And so I wanted to basically work on that problem, figure out how to fix that within emergencies. I left the city. I worked at Planned Parenthood for 3 years, running preparedness and response for them during COVID, and then came back to Columbia about a year ago to start this Pandemic Response Institute journey that Danielle mentioned.
Wow. Excellent. NightWatchman, because I do know some of your background in terms of being the CERT. Explain that.
Okay. So first, we out of Hurricane Sandy, we had started at WHCR, our radio station, an emergency response team, or we called it emergency broadcast team, because we felt that as a station we didn't respond as well as we would like, and so we wanted to. I think Sandy created a lot of efforts around the city in terms of people recognizing how unprepared we were for it. So in getting that started, I went through the CERT program, which is Community Emergency Response Team program that's run through New York City Emergency Management, funded by the federal government. Subsequent to that, we formed the Harlem Emergency Network, which we kind of developed a community-based communications network to also respond to emergencies. So through those interactions, we've had a chance to interact with NYCEM, New York City Emergency Management, Department of Health and Mental Hygiene, and other stakeholders in emergency response and emergency preparedness. So I like what you were saying, Mitch, because you hit on what I think are some of the hot buttons of the disparities that we saw when the pandemic hit in terms of response and resources. And so maybe you can tell us a little bit about your thinking in terms of creating the Pandemic Response Institute and what your goals are for that entity.
Well, first off, shout out to the CERT teams, right? I love that emergency management program. I love the Harlem Emergency Network. That's a great conception and organization. I want to say, first off, the Pandemic Response Institute was actually the brainchild of New York City. Real shout outs to both the New York City Health Department, New York City Emergency Management, and the New York City Economic Development Corporation, because during COVID, they really saw this problem, right? The health department hired thousands of community health workers to go out in the streets to look at these disparities. Emergency management changed the whole structure of their operation to try and hit these problems. And during COVID, the city sort of realized that it needed a new kind of public health resource that was independent of government, but kind of tied to it, to help to help this issue, right? To help neighborhoods across the city become more prepared and resilient. So the idea for the Pandemic Response Institute really came from the New York City government, put out an RFP that was won by Columbia University with our key partner, the CUNY School of Public Health. That's why Danielle and I are tag teaming here today with this mission of whole society resilience. Not meant to be a think tank, right? Not meant to be like a consultancy group giving advice to the government, but really meant to be out there working neighborhood by neighborhood, not even on the front lines, but supporting the people that are out there on the front lines, like your CERT team, doing the work that they do better, figuring out how to get them the resources they need, figuring out how to make all of New York City come together to respond to these emergencies and get ready for them. That's really the vision. And I really credit New York City for the foresight and thinking ahead to see that need.
And Danielle, I certainly, besides being on the advisory board with the CUNY School of Public Health, I really didn't know much about their real, mission to really work within the Harlem community, or as they say, underserved communities in New York. So can you tell me a little more in terms of their real goal and mission and what they've been doing in terms of training some of their staff to do?
In terms of the Harlem Health Initiative and the school's efforts in Harlem. Oh, wow. So, part of what we're doing is also trying to build connections between PRI and what both schools are already doing. So, at the PRI is set up with 7 teams, and one of these teams is the community CCLT, Community Convening and Learning Team, because it's really about working deeply within the communities, this whole of society, but particularly, community organizations, faith-based, service providers, as well as small businesses, big businesses, government, academia. Everybody got affected. The supermarkets, right? Everyone was affected. People who worked in supermarkets were considered essential employees, but they weren't treated the same way frontline workers were, first responders. So we're really working to apply the lessons learned to make things better for everybody. And part of that is one of the leads of our community convening team is Deborah Levine, who is also the head of the Harlem Health Initiative, which is what I think you are referring to. And the Harlem Health Initiative has a number of programs where they're working to bring education, health literacy, task shifting, which is a big thing in mental health right now, because we have such a mental health shortage. How can we train other people within organizations to work with people on their mental health needs, help them get to resources so that the limited number of psychiatrists and psychologists can work with more severe cases, but everybody's getting what they need. So that's like with some of the on the ground work. And the way that ties back to PRI, as Mitch said, when we do these emergency responses, we're not always getting resources to who needs them. We're not doing it in a way that actually helps people. So how can we make that better? But at the same time, you can't layer emergency response on an already broken system or on places where there's already huge holes, right? Like you don't just cover up a ditch, you fill the ditch. So how do we, in an ongoing way, make things better so that there's a better place for emergency preparedness responses to land so that everyone gets helped and everyone gets access?
Gotcha. Well, I guess one of the things, so obviously COVID pandemic, right? And there had to be a response designed around that. But you guys with PRI are ready for, will be ready for future pandemics, no matter how they come to you, Mitch?
I think that one of the ideas that's core to emergency management is the idea that you can take an all hazards approach to things. A lot of the disasters we're going to see, unfortunately, in the next 20 or 30 years, even though they're going to look different on the outside, they're going to share a lot of the characteristics on the inside, right? In terms of disparities and harm. So Pandemic Response Institute, the name's a little bit confusing because it's not just pandemics. We're here to support any kind of public health emergencies, particularly climate change driven disasters like the likely increase in heat waves, for example. We're not as focused on response because what we're trying to do is work with all the neighborhoods to make sure that they're ready and resilient, right? So our role is stronger in the preparedness phase or in the recovery phase. We are an institute, so that part is right. But pandemic and response, it's a little bit broader than both of those ideas.
Gotcha. Well, and do tell me, Danielle, with the work that you guys are doing, where is, let's say, a white paper or a report out going to be going, and who's going to then be responsible for implementing some of the findings that you guys come up with?
So that is a great question. As Mitch said, I think he usually says this, we're not a think tank. So we are trying to be very much about pulling the information together, putting it out there, and then accountability. So we have done some conferences where we've then posted the recommendations on our website. We've given them back to city partners. We've had conversations with city partners about how to implement them. We're also looking to change systems and really bring everyone into the conversation. So a couple of the things we're doing on this right now is something we're calling a COVID-19 review. But it's not a critique of government or what happened. It's more looking at what did happen, checking out, listening to everybody from the whole of society about what happened, what they wish could have been different, and then having conversations about the findings at all levels so that we can make plans, but not like PRI will implement this, not that the government will implement this, but that everybody in their sectors, in the ways that they can, how can we push forward different approaches, do different things? And obviously then finding resources for that will be critical, and that will be a whole of society thing that we need to do too. So a good example of this, if I can go another minute,
absolutely,
is this convening that we're having next week that I know both of you have received invitations to.
Yes.
The seats are limited. It's called Leaving No One Behind, a systems approach to pandemic communication. And what we're saying is communication is a system. There's the information. There's the sources of information. There's the communication channels, and there's the information users. And we haven't looked broadly enough at each of those areas and all the different things that affect how information gets out, who then translates that information, how it lands. And if we're not going to look at all of that as a whole, then information is not going to get to everyone who needs it, which we saw during COVID, or it's going to get morphed, right? There's a lot of misinformation, disinformation, or it's just not going to resonate because we made assumptions about all people reacting the same way or needing the same type of information. And that's not true. How you interpret information, what's going to motivate you behaviorally to do something with that information, if we're asking you to change your actions, depends on a lot of things about who you are, your lived experience, who you interact with. And if we're not looking at that whole thing as a system, we're not going to be able to do better with getting information. And information was really key to how we protected people during COVID and will be during other emergencies.
Gotcha. NightWatchman, I see you about to pause to say something. Go ahead.
Oh, well, yeah, I think what you just said was so relevant. one of the things that we did at Harlem Emergency Network at the beginning of the pandemic, we were not satisfied with the information we were being given. So we started doing our own information broadcast. So we did a weekly COVID update from, I would say, late March of 2020 for the next year and a half going into the pandemic, just to sort out what was being transmitted to us versus what we were also seeing in our neighborhoods. And so we saw the disparity. We saw number one, there was obviously, we can all say that, nobody was really fully prepared for the pandemic. But we also saw the schism between the state and the city, which was politicized at the leadership level. We had a governor and a mayor that did not play well together. And I think we felt that come through in terms of the city and state response not always being in sync with each other. And especially in the early days where we would have our mayor, which was de Blasio at the time, say one thing and Governor Cuomo say another. And so I think one of the issues about communications, especially during a pandemic, is trust. That if we don't have a trusted source for information, then it becomes open for disinformation, misinformation, and a certain level of chaos in terms of getting the messaging out. So I guess I would turn that back to you guys and just get your thoughts on how to address that going forward.
Mitch?
That's the question, isn't it? Especially in this day or age. You guys only ask the easy ones.
Well, luckily you guys are new, so none of the blame can go on PRI. So you're in a position to ask some of the questions that I think need to be asked in a respectful manner, but we still, I think, need to look at those issues.
Yeah, I think, well, the first thing I want to say is I just want to sit for a second and acknowledge the tragedy of COVID, right? Because we talk about moving on or the pandemic's over, and we know it isn't for a lot of folks. We know that long COVID is still causing harm. We know that lots of people are still dying from COVID every day, right? It's still a leading cause of death, even though we've declared the pandemic over. And and I do think we didn't
declare the pandemic over. The federal public health emergency is over. There's been a lot to say, no, the pandemic's not over, but
right.
Sorry.
No, that's right. That's right. The feds declared the public health emergency over. And I actually do think we all sit with a little bit of that responsibility because one of the magic things about PRI, one of the reasons I think the approach is important is because, as Danielle mentioned, the idea is it's a whole of society approach. And to respond to these disasters or emergencies, it's actually bigger than what government can do alone, right? Our government isn't designed to do the kinds of things we expect it to do out of the blue in an emergency, especially when you haven't given public health infrastructure sustainable funding for the last 10 years.
Wow.
Right. And so, as Danielle said, you have these broken systems that you're starting with. And so what we are trying to do on this question of trust is create spaces where people from across society can get together to have some of these deep conversations that we're scared to have right now sometimes. So let me just give you one example. PRI has 7 faculty-led teams, and one of them is the Innovation and Scaling team, which is actually led out of the Columbia School of Engineering. And they've decided to focus on diagnostics. COVID testing. What went wrong with COVID testing, right? And all of us kind of suffered. I remember in March of 2020, the sirens just going by my door, right? And having really no way to know whether my family had COVID or not at that time, right? Just not having access to that. And so what PRI did is we didn't get a bunch of bigwigs together, right? We didn't get a bunch of governmental leaders together only, or we didn't go just to the companies that made these tests. We didn't go just to the community. we brought all three groups together so that we had community leaders there. Shout out to Maria Forbes from the Night Tenants Association. We had the big testing companies there, like Becton Dickinson, who makes the little cardboard containers of COVID tests you've got in your home, or Quest Diagnostics. And we had leaders from the city public health lab, the state public health lab, from the federal government, all in a room having small group discussions about, honestly, what went wrong, trying to get everybody to be vulnerable, step out of the talking points that they've got, and really get to the underlying issues, not just technical, not just how do we, build the technical infrastructure, how do we change the culture, right? How do we make it so that we can understand that if a person can't read the instructions on a test, that matters from a design standpoint, right?
Wow.
That if we don't distribute these tests in ways that they reach the people that need them most, that's a problem for the companies, not just for the community, right? So if we can share these problems together, I think it'll both help testing, but I think it also gets to this question of trust. How do we solve these, what we call in emergency management, wicked problems, really complex, hard to understand problems?
And on that point, Mitch, in terms of, let's say, what was then being reported out, let's say, from the federal government to, let's say, even a state like Georgia, or a state like, let's say, Florida, and then, of course, New York. How is that all, being received by, let's say, populations that you're dealing with?
One of the big issues everybody's pinpointed in COVID is the question of data. We actually have one of our other teams, I'll just list all four, and we have 4 technical teams in PRI that work on these sort of more technical issues. Innovation's one of them, epidemiology and modeling is one, workforce development is one, and then data sharing and analytics that you're asking about is another one. And we've heard that the data that unfortunately public health infrastructures had to rely on is old. People are doing things on Excel spreadsheets and emailing them back and forth. There's not a fancy data warehouse of the kind that you hear of from Google's or Amazon's or those kinds of folks. So the issues were, I think, 3 issues. One is that every state and a lot of localities reported things differently. A lot of them didn't disaggregate their data by race and ethnicity, especially at first. So nobody could see these disparities. And if you can't see them, you can't solve them. Yeah. Issue 2 was we didn't share the data. There was no clean way to bring all of this data in one place so that you could analyze it as one country, right? We were trying to do it piecemeal. And the third thing was everybody had a different underlying system. People were using different technologies. Those technologies didn't talk to each other. And so even if you wanted to, you couldn't dive in and really look at the cultural drivers of these issues.
Wow. Incredible.
So what we're doing at PRI, and then I know I don't want to monologue about it. I just feel so strongly this is important, is our data team is going to start convening and are starting next week with a small group of folks to look at some of these issues, to plan a series of data expos where we bring folks together to look at this data problem to see what technical fixes we can get, but also how we can open up some of the culture of data sharing to make that easier in emergencies going forward.
Nice. And NightWatchman, you heard about the word that you're afraid of, convening. You heard that.
Oh, actually, I'm looking forward to convening because all of the things that Mitch just mentioned are so important and relevant. And what we saw from the ground level was just, even when there was issues where we knew what the data was, we did not get the resources allocated where they need to. When we knew that the pandemic was raging in East Harlem and the Bronx in particular, and yet we saw in the early days of the pandemic, they set up resources in Central Park and downtown. And, and when testing, finally showed up, we had to fight for testing in our neighborhoods. And when they said testing was available, we would check it out. And it was either not available or it was, signage was in a way that no one knew it was there. And we saw a repeat of it when vaccines rolled out, and vaccines were supposed to be in our neighborhood. No one in our neighborhood knew about it. And yet somehow people upstate were coming in and driving in and getting vaccines, while people who lived down the block didn't know that they were available. So we still want to see how, data sharing actually yields, resources being allocated to where it needs to be, versus, we still don't understand how and why those resources were allocated in the way that they were. So those are all kind of after action things that we need to review so that we can do better the next time. And I'm so happy to hear the approach that you guys are taking in terms of putting everyone at the table, having the tough conversations, and looking for solutions.
Absolutely. And Danielle, tell us, because what Bob was just saying, I mean, please.
Oh, yes. How'd you know I had some things to say? I can tell I have an expressive face. So I think, Bob, you were so right on so many of your points, because there's so many factors that went into this. And it goes back to what you said initially about this was a local response and a state response and a federal response and a global response, but the responses weren't always aligned. And, we do have a structure that allows sort of, what do they call it? New York's a home rule state. So, but a lot of this was politicized, but also people were doing their best. I think all of the state, local, federal agencies, the non-political positions, people were working so hard and trying to do their best. And we really do have to give them credit. And they were also trying to look at how they could get maximum impact. Yeah. So putting up like a testing site or a vaccine site in a central park makes sense if you're looking at it from where can I put the biggest facility in the most central place that the most people could access at one time. And so there's a logic to that. At the same time, you have to look at where is there the most need. Can those people easily get to this most centralized place? What would be the barriers? What else do I need to do to make sure the people most in need with the least ability to go somewhere can get what they need? And I think at times things were looked at one way or the other way, and not at both ways at the same time. And it also goes back to what we're saying about communication, right? How did people know those things were there? And why was it that people upstate knew more than people right by here? I mean, we saw the same thing during MPOX when the clinic started offering the vaccine. There were places in Harlem that were offering it, but when you looked at who was online there, it didn't look like Harlem residents. So again, how do we going forward balance that out? And then the data, so much of that is about we need to invest in our data infrastructure and our public health workforce. Because part of why people were using Excel spreadsheets and sharing data that way is our data systems are very old and very clunky and not easy to adapt to a new situation. And we haven't, as Mitch alluded to, we haven't made the investments in our public health system. And even now, when I say that, people are going to look to pay, our hospitals and healthcare, but public health, pure public health, what health departments do, what the universities do, collecting that data, crunching that data, pushing out community health workers and information, and the epidemiologists that are doing cluster investigations. That's where we keep cutting, and we only invest during a crisis. It's this kind of surge and neglect cycle. And we're about to go into another neglect cycle. And this is when we really should be building up our public health workforce.
Incredible.
I also I just want to add to what Danielle said, because I want to make it clear that even while I'm critical of some of the responses, we had tremendous efforts by the people at New York City Emergency Management, Department of Health and Mental Hygiene, New York City Health and Hospital Corporations. And as you said, Danielle, people did their best in many times horrific situations. So I think it's important that we do acknowledge everybody who did their best and fought valiantly, and had triumphs and had some losses. But I also think that now is a good time for us to try to look back objectively and critically and identify the pain points and seeing what our solutions are.
And I guess I have to ask, okay, so PRI, is it unique to New York? In other words, other states, other cities, have they not thought about, let's say, getting some institutes of higher learning together, collaborate on this type of issue, and then maybe like share some information and data with one that's already up and running? Mitch, are you guys the only one, the only game in town?
Well, let me start by saying, adding to a little bit of the praise there for the Health Department Emergency Management is a way to get at that question, because, I think, I was actually out of the city. I left the city about 6 months before COVID started, right? And so although I'd been there for 10 years. And so I talked to a lot of my friends there during this time, and they were working hard, but they were sleeping at the offices. One of my friends was attacked on the way to the subway. People were yelling at him and spitting at him because of some of the frustration in certain parts of the city about some of the public health guidance. And so I think that we should absolutely say that there are things to learn. There are always things to learn. They were so conscious of and fighting so hard to address these disparities. The way I look at it is they were trapped in these structures, kind of just like all of us are. You know what I mean? They were fighting to address the disparities, and kind of the underlying flaws in the system that Danielle were talking about are so strong that it was hard to break through them. And that's why this idea of sustained public health infrastructure is so important. And I promise I'm going to answer your question. I'm going to say one more thing to get there, which is, after the 2001 anthrax attacks, the federal government actually spent $28 billion on health stuff for emergencies. $28 billion.
Wow.
To get us ready for health emergencies. Of that money, how much was spent on public health infrastructure, was spent going to states and localities to help these public health systems? And the answer is about 0.8%.
What?
Of that money. About 0.8%, because the most of it went to hardcore, high-level technological research into vaccines and new technologies, which is important.
Yes, it is. Yeah.
But we need that safety net. And that safety net needs to be there and sustained, because that's the only way we can get at these disparities. And now I'm going to answer your question. New York City did something really unique with PRI. PRI is the only model like this I can see. I was at the Preparedness Summit hosted by CDC a few weeks ago. Couldn't find anybody else. A lot of research folks, a lot of think tanks, a lot of people analyzing these problems. But New York City realized they needed to help society to address these systemic issues, and was unique in taking this step to found something like PRI, that the job is really to go out there neighborhood by neighborhood, helping the whole of society get ready. So I think it's unique, and I think it's so necessary to rectify what we've seen in the prior decades.
Wow. So yeah, that's a little disheartening, but hopefully, it can be replicated other places. But I mean, Danielle, tell me your thoughts on that.
I think what Mitch said about PRI, we're unique. There are other pandemic institutes, other places. I think what we do and how we're set up definitely is unique. I wanted to comment on something Mitch said in the lead up to answering your question.
Go ahead.
Because there's two things about preparedness or public health in general. And I think that's what makes it so hard for us to sustain the type of funding we need for public health. When public health is at its best, you don't see us. We're preventing these situations, right? Like there's restaurant inspectors. They're going in, they're making sure that you're not going to get food poisoning. We're, testing the mosquitoes and the ticks to reduce Lyme disease and mosquito-borne illnesses. Like, remember Zika?
Yes.
We didn't have a Zika outbreak in the US, that it was all travel-related cases, is because public health was able to do its job. So, we prevent things, and then if we prevent things, people think that it's not needed. So that's why it's so hard to sustain funding for this infrastructure that's so clearly needed. The other thing is preparedness is tough. Like, one of the things people have been saying for both COVID and Mpox is, well, why didn't we have in the warehouses the things we needed? And we have to remember, why weren't we stocked up? And there's a couple of things, like medicines expire, medical equipment, protective equipment expires. So you have to keep investing in it and re-upping it. But also, pandemics are different every time. Like if we'd stockpiled based on what we knew in advance, I'm not sure that we would have had everything we needed. If we now stockpile gloves and masks and tubes and other things we really needed this time, and the next virus is not respiratory.
Wow. Yes.
We still might not have the things we need on hand. So it's looking at all of this.
But we still there's still the issue that we saw, which is supply chain, and we saw the dependence we have of goods coming from China. And when China had their pandemic first, their first priority became China, and so that led to the shortage of masks at the beginning. And also that created mixed messaging, because the message went out that N95 masks originally said were only for health workers, when they were clearly sold in stores all the time before then. And then afterwards, when things eased up, then there was a call for people to wear masks, but there was a gap where they were saying only give the masks to the health workers. So, and I think that was the supply chain issue. So we have to at least look at that going forward, whether it be masks, whether it be medicine. How do we set ourselves up to succeed when you have something like a pandemic that can scale to be such an emergency so quickly? So, Mitch, have you solved that problem?
That's the easy question number 2, right? I'll tell you that, one thing a lot of people don't know is that the New York City Economic Development Corporation during COVID invested in a bunch of homegrown solutions for New York City to try and build up a New York City centric supply chain for this stuff. One great example of something that was incredibly helpful was the Pandemic Response Lab, which took on the job of doing rapid turnaround COVID testing for the city. It was created essentially out of nothing, spun up into a huge enterprise, and was recently sort of backed off and decommissioned because, it was created for COVID itself. But there are other things like that too. They looked at other kinds of lab capacity, at building masks, building face shields, 3D printing various kinds of medical equipment. So one intent for PRI, one reason the Columbia College of Engineering, School of Engineering, is leading our innovation team is to address this problem, is to look at New York City driven solutions for the supply chain. New York City has dozens of homegrown labs in in neighborhoods all across the city. We have a lot of capacity. We have a lot of manufacturing capacity, even still in 2023. The question is, can New York City leverage that in an emergency to sort of tune it to what we need so that we're less dependent on global supply chains? So we haven't solved it yet, but I want to note both that New York City made a lot of strides in that direction during COVID, and that the Columbia School of Engineering with the Economic Development Corporation, with some great faculty from the CUNY School of Public Health, are looking at these homegrown solutions for New York City right now. Like I said, we're looking at diagnostics and testing first, but there's a lot of other science and innovation that we'll deal with in the future.
You know, Mitch, I'm an alum of EDC, New York City EDC. So what you mentioning them again and again, me knowing them from the real estate part, like, is it because of they're big into the real estate that they were able to also find, let's say, space and or facility and make that capital investment to build out certain things?
So in the way the city approached COVID, the city health department was in the lead, emergency management was the coordinating body. But one of the unique elements was that the EDC, the Economic Development Corporation, came in to do public and private sector partnerships. Wow. So in addition to real estate, EDC also has a life sciences portfolio. So they invest in labs, they invest in innovations of different kinds. They have a bunch of investments in all kinds of innovations across the city. So it was that wing that really stepped up. Sue Rosenthal runs that, and she was really at the center of trying to figure out how to invest, not just in real estate, but in scientists, in manufacturing capacity during COVID. A really cool thing that I wish more people knew about our COVID response in the city.
Wow, incredible, man. Well, I guess what I definitely am wondering, and Mitch, I know you mentioned this earlier, and Danielle too. I want to know, in terms of, where do you see this next, let's say, issue, catastrophe, pandemic stemming from? What do you think? If you had to use a crystal ball, I know there are none, but if you had to use a crystal ball, what do you think, Danielle?
So when I look back on the health emergencies we've had over the past, 5 years, I don't know that we would have predicted any of them. Zika, COVID, Ebola, the fact that we had measles outbreaks and almost lost our measles elimination status because people weren't getting vaccinated anymore. I mean, they've come from all over, but I think that, a lot of it is climate change driven. We're really changing the ecosystem, and that's affecting how viruses form and transmit, and that's having a huge impact.
Wow. And Danielle, let me also say this. Okay. So certainly we know that Hollywood sometimes has a little, maybe a finger on the pulse of some things. So outbreak, contagion, you name it. So I was like, oh my God, can that really happen? And so I'm thinking now, you mentioned all those other particular potential outbreaks that didn't happen. Now, we certainly do know that cyber attacks occur all the time. Viral attacks, do they also occur all the time, but we're able to head them off?
Yeah.
So literally we're being attacked right now, and it may be being mitigated, and we won't even know about it.
I mean, I don't want to make it sound like there's some conspiracy out there.
No conspiracy.
About some virus, Curtis. I mean, just that's how Hollywood is. What I mean is, there are many things our bodies can fight off.
Okay.
Right?
Gotcha.
And because we have, good hygiene, we have protections in place where we're looking for things, to prevent food and, contaminants getting in our food and water, because we have these larger surveillance systems that, we even have wastewater surveillance now that can kind of pick up blips of things and look into them. And there are ways to mitigate and catch things early. And then there are things that you don't see in time, or they spread too rapidly, or the impact is so severe that you do end up with situations.
Gotcha. And Night Watchman, I'm not going to bring it up, but we do remember the film back in the 70s, Three the Hard Way. Remember that?
I never saw that one.
Oh, wow. And Mitch, forget him. Go ahead.
Oh, you.
I'll tell you, my favorite one is The Day After Tomorrow. You ever seen that?
Oh, yes.
Everything freezes in 24 hours and they're running through the public library and the ice is chasing them down the hallway because of climate change. You know, the thing I want to say is that one of the issues with funding after the anthrax attacks in 9/11 was that we got fixated on this idea of bioterrorism, right? That people were coming to get us with these agents, foreign power kind of things. Whereas in fact, the pandemic cycle, the genetic drift that we see in diseases naturally was where we really should have invested more of that. And it points to this problem with our own imaginations. And I think Hollywood contributes to this, where Hollywood teaches us to imagine disasters in certain ways, right? Like they need action heroes. You need like a Chris Hemsworth or you need The Rock, like driving a car across a cliff to solve these things. When in fact, what you need are communities standing up and joining hands together. And the reason you don't necessarily want to focus on this or that cause of disaster is because what you really need is to fix these systems that are already broken in society, right? If you can lead to human flourishing, those things that are systemic flaws are the same things that are going to cause harm when disasters come. It happens every time, right? The underserved communities always bear the brunt of disasters. And so in a sense, the disaster, it's not coming from outside. It's not the ice chasing you down the hallway, right? The disaster is the fact that we let these disparities continue to exist in our communities. And if we could invest in them now and build the infrastructure up on a day-to-day basis to sort of solve them and let people lead more liberated, flourishing lives, these external things, when they come, would have much less power over us, right? Because we'd have much more capacity to resist them. So that's what I would like to imagine. And that's what we hope PRI can sort of help people to imagine, is how communities can stand together with mutual aid to kind of take care of each other, whatever comes our way.
Okay. Night Watchman, I saw you poised to something to say.
No, just listen. I totally agree with Mitch, and I think that's the big problem, but also the big solution. In particular, I keep thinking about the Bronx, which going in before the pandemic was known as the county in New York that had the worst health outcomes. And so what we saw with the pandemic was that that condition exacerbated the results for that particular community and others such as it. And so I think Mitch has his finger right on the hot button right there, that the issues that existed before the pandemic only get exacerbated by the pandemic. And so if you could address those systemic issues, which are probably the harder problem, because they've been there for so long and they have, there are a lot of factors contributing toward it, but having better overall health is part of the resiliency of preparing for future emergencies.
And I guess I'll have to ask, I didn't ask it earlier, but the data that you guys, of course, are collecting, assimilating, so forth, it is also broken down to the micro level in terms of race, ethnicity, age, and so forth, correct? Because I remember you mentioning that in some other states and municipalities, it was not, but yours is.
I'll just, I want to give credit. This is the New York City Health Department. They've really done a great job of figuring out how to break that down at the micro level, below the census tracts, looking straight street to street. We are really looking at it in how do we support them? How do we modernize that? And also, how do we make sure that neighborhood leaders, community leaders have the right level of access to data they need to help their communities, so it's not as centralized as it is right now. But we are not, we are out there helping society. We don't manage the city's health data, But the city health department has done a really good job of figuring out how to get that out to the people that need it at that level of granularity. It's impressive, and it's more than any other urban area has been able to do during COVID. That's for sure.
Beautiful. And Danielle, certainly you mentioned earlier when we were talking about how you had to report out to community boards. Are you still doing that in terms of what you guys are doing with PRI?
Right. So PRI is, and through CCLT and through we also have a communication team and a race, equity, and social determinants of health team. And we call those teams cross-cutting teams because what they do affects all of the work that the other teams Mitch mentioned and vice versa. And so, yeah, we're meeting with community leaders, community boards, government officials, bringing groups of local community members and CBOs together. And going back to the data point, going back to something we said at the beginning, like you could have looked at those disparity maps and you could have looked at what the Bronx looked like and where the high rates of asthma and diabetes and all these other conditions were and predicted where COVID was going to hit the most. And we need to work, and more of what we need to do at PRI, working with all our partners, is that kind of advanced planning, because it is about fixing, looking at the broad systems as well as the local systems to fix the ongoing disparities and the ongoing issues of lack of resources. And we're going to see that going forward, because with the end of the federal public health emergency, things are going to change about what's available.
Gotcha.
And so we need to really be paying attention to how are people going to get access to tests, and what does it mean that tests may be more broadly available, but they may not be free. And how is that going to affect people? A lot of small things like that are going to start changing. And we need to look at how we can address disparities in those issues and work with community and government and business to make those things better.
Wow. Danielle, you tell me these tests will no longer be free because we're no longer in this public health emergency?
Well, the federal government was buying all these tests and sending them out, right? You filled out your thing, you got your 4 tests in the mail.
Yeah.
That's gone now.
Wow. Oh,
it's going to go back. It's good and bad. We're going back into traditional health systems, right? Where you go to your doctor, you go to the urgent care, you put things through insurance. But then that also means that there are people who didn't have access to those systems or who can't afford co-pays. And so we're going to have to track. The one thing I will say, and this goes back, Bob, to what information gets out there, your tests that you have at home that you've collected when everyone was giving out all these tests may not be expired. All of those home tests, as they've learned more, they've extended the dates that they're good for. So before you throw a test you have at home out, go onto the website, look up, is my test expired? You can look at, I think it's an FDA website, but you could also just type it in for the manufacturer of the test you have at home. A lot of those expiration dates have been extended twice. So as we're in this shifting time, I really encourage people to double check their tests and don't assume that they're expired.
Gotcha. NightWatchman, I guess. Go ahead.
We are at the end. It's been a great conversation. We're so glad you guys were able to come and share what you're doing, and looking forward to the convening.
Well, I want to know, how do we get in touch with these guys? Tell me.
Well, I'll tell you, you can get us all the time at pri.nyc, easy address to remember, through Google. We're on Twitter at the NYC PRI, and we've got a newsletter. We do a weekly update on public health emergencies around the world that's helpful. So there's a lot of ways we can you can reach us. And PRI, it's important, is a joint partnership between Columbia and CUNY. So you're not reaching out to Columbia, you're not reaching out to the CUNY School of Public Health, you're reaching out to this joint initiative PRI that really spans the city. Let me just say one last thing to Danielle's point, which is, we've heard a lot about the fiscal issues the city's going to hit, right, in the next few years. The federal support for COVID because of the end of the public health emergency, that's going away too. The city is going to lose tens of millions of dollars in federal support that's paid for community health workers, that's paid for testing initiatives. So as a city, we've got to decide, what are we going to invest in? And I think history shows that if we invest in public health infrastructure, we are going to be much more ready to stand up and support society in these public health emergencies. So anybody that's listening, that's the path that we need to take, is to make sure that we can support these skills and programs long term.
Beautiful, beautiful. Danielle, closing thoughts?
I think Mitch took the words out of my mouth. These disparity things in the way of, building on solid ground, needing to fund public health infrastructure. I mean, it's a tight fiscal year for the city, a tight fiscal year for the state. But we need to really look at what's important and how we're going to reinvest, and how investing in health leads to workforce investment and small business investment. And it really is the underpinnings of a healthy society that is also economically productive.
Beautiful, beautiful. And NightWatchman, I know you got tremendous benefits from this, because I no longer hear that ambulance outside your door. So this is good. Gotcha. Anyway, so NightWatchman, take us home.
You've been listening to Soul Lounge Primetime on WHCR 90.3 FM, the voice of Harlem. Also live streaming on YouTube and Facebook, and on all of your favorite podcast platforms, including Spotify, iTunes, Amazon Music, Google Podcasts. Ask Alexa to play the latest Soul Lounge Primetime. Ask Siri, ask everybody. Thank you for joining us. We're always on Monday nights, 7 p.m. on the radio, 8 o'clock we're live streaming. So share this with your friends and join us next week. We have something even better. We don't even know what it is.
Anyway, I gotta say, Mitch, Danielle, love you guys. Great show. Perfect.
Thank you.
Yeah.